Good evening. Buenos dias. That's the extent of my Spanish, sorry. Thank you all for coming here today. We would like to welcome you and welcome people who are joining us on live streaming as well. Today, we are taking the opportunity to have this round table, which is the third of a cycle of discussions initiated by MSF Spain, where we talk about the challenges of working in conflict settings, humanitarian medicine in conflict settings. The two previous ones, we had one in May where we talked about our work in Yemen, and a second one a couple of weeks ago on the attacks on hospitals. Both can be seen on the MSF Spain YouTube channel if you have missed them. We thank our guests, we thank you, and we thank, of course, Casa Encendida for being a good partner and for hosting us tonight. Tonight we have a few speakers from MSF and from the ICRC, and I will start by introducing myself. My name is Tamam Al-Audat. I am a Syrian physician. I've worked as a humanitarian medical worker for the past about 17 years now, between the International Red Cross and MSF. In the past few years, I've worked in the headquarters of MSF Holland and now in MSF Switzerland in Geneva. Today, we're going to talk about how the context of insecurity affects our ability to provide humanitarian medicine. And to start with, I'd like to just give you a little incident I've been subject to about a year ago, almost exactly a year ago. You will have heard of the conflict in Yemen, and Yemen is a country that has seen several wars in the past few decades. The one we have now is probably one of the most intense and devastating to the population. I was part of a team of MSF that went to explore the possibility of implementing a new medical program. And we landed in Sana'a, the capital, and we traveled by car to a city called Ib, where there were about 1 million internally displaced people and very little health services. Yemen is a country that is known for not being very peaceful. One of the statistics that are fascinating is that there are about 2 to 3 pieces of weaponry per person in Yemen. That includes the babies, the children, the elderly, and everybody. Guns in Yemen are pretty common. But this is a statistic. It's much more difficult to swallow when you are sitting in a car and driving in an MSF car and trying to reach a hospital in a different city, in what is a beautiful landscape in a country that has seen much devastation. In the hotel, the owner introduced us to his son, 11 years old, and on his 11th birthday, he has received a pistol as a gift. He was carrying it around proudly, and I asked, and it was loaded. This was interesting in 2 ways. First, a child of 11 years old with a pistol should be scary, and I wasn't very scared. And second, this is absolutely as abnormal as things go. And this is one of the manifestations of working in conflict today. Conflict is not safe by definition. And as humanitarian workers, we don't expect to have absolute safety. In fact, if you go back to the charter of MSF, you'll find a significant part that says people who work for MSF understand the risks that they are subjected to and take responsibility for them. This is something we have lived through. We have seen conflicts, we have lived through them. We have gotten used to seeing guns, checkpoints, and to having what you'd call a safe room in our residence in the field. But today, what we're arguing is that the conflict is changing and the nature of risk that we are subject to and the population of a conflict are subject to is entirely different. How is the context different? I will argue that today we have seen situations in the past years where medicine itself has started being used as a weapon. The availability or inavailability, the prevention or targeting of medicine and medical facilities has started being used systematically as a weapon of war. And this is something that would have been probably unimaginable to many of us 10 years ago. We have new actors. We have actors that stopped being able to follow the customary rules of war. In our world, we, as humanitarian actors, we do not argue about the legality of waging war. We argue about the legality of actions within war. We say that you wage a war, you have a certain set of boundaries you do not cross. They are being crossed on daily basis, partially by governments who are signatories to the customary law that prevents such acts, but with the emergence of new actors like the cross-border non-state actors. You will have heard of ISIS as one example, but there are multiple groups that are active today that do the same. But even the fundamentals of war are changing. You will have heard of attacks by drones, people sitting, playing with joysticks, control and target morbid weapons that cannot address certain persons but address patterns of movement. They don't know who they are killing. And they have and will continue as they are used to target civilians intentionally or not. This comes with an escalation of all kinds of risks. In the past years, between Central African Republic, Congo, Somalia, Yemen, and Syria, we have seen humanitarian aid workers being kidnapped, being abused, and being targeted particularly. And this is one of the things you come back with, and whether you figure it out immediately or it takes years, is that all this isn't easy to take in. There is a significant level of psychological impact that this has. Today we're going to talk about the outcomes of that. What does it do? And I will just skim through it very rapidly because my colleagues will go into details. This has so many layers. And if I want to deliver one message today from my side, is you will see on the CNN and on the news people who are trauma victims, people who have seen explosions and gunshots and so on. This is a stark and unacceptable situation, but it isn't by any means the only one. Conflicts today disable the health system, cause the normal diseases to become untreatable. People with chronic diseases that are easy to treat aren't getting treatment. Complicated pregnancies are killing mothers and children, and outbreaks are spreading because we have no more of the preventative and curative aspects of the health system that used to exist. This affects the national health system. This affects the local providers, the doctors and nurses and health workers that try to continue to provide health care in conflict areas. And this affects us and other humanitarian workers. What we have to do today, again, was unthinkable a few years ago. We had intentionally and consistently in MSF said that our proximity is essential to our work. What that means is having international aid workers sit close to the patients and treat them directly rather than provide only donations from far away is critical to our identity. It's critical to our ability to be accountable, and it's critical to carrying our voice, providing témoignage, which is witnessing what is happening. This is much harder today than it has ever been in my experience. I will leave you here for a moment and move towards our colleagues. Today we have a rich panel. We will start with colleagues from the International Committee of the Red Cross in Somalia. We have Maurizio Campaya and Gail Corbett. Maurizio is a nurse who has joined humanitarian aid in 1999 and has worked starting in Kosovo and then in a whole list of countries, many of which has been in conflict, including Eritrea, Angola, Namibia, and South Sudan. And he joined MSF in 2007, where he worked in Darfur, which is a conflict, and then in an Ebola outbreak in Uganda. Later on, in 2014, he's been with the ICRC and started working as with the mission of Afghanistan, and currently the health coordinator for Somalia. I will invite Maurizio to give us his view, and the ICRC will speak about overcoming access issues in Somalia. Do we have Maurizio? I can continue speaking. I'm sorry for the speakers, but I will have to be slightly strict on time. So we'd leave a chance for questions in the end. Maurizio and Gail, thank you for joining us. This is Tamam from MSF Switzerland, and we're very happy to have you. We have introduced Maurizio, and we'll give you the next 6 to 7 minutes to give us your view on access to healthcare and humanitarian aid in Somalia. Maurizio, can you hear me? We can't hear Maurizio. I'll take the opportunity to introduce Gail as well, just so we use the time. Gail is a nurse, I believe, from New Zealand. She's worked also in Afghanistan with the ICRC as a nurse trainer, and she's worked also in Iraq and Gaza in Palestine. And for the last 20 months, she's been the hospital program manager in Somalia. The ICRC runs today 4 hospitals in South Central Somalia, and they support the Somali Red Crescent in 32 primary healthcare centers. Up until 2 years ago, the programs were mainly run by mobile staff based in Nairobi, working with resident staff of the Somali Red Crescent Society based in Somalia. The last 2 years, there has been an increased access to the programs in the field for the mobile staff.
Hello?
Yes.
I'm very sorry for the... Yeah.
Yes, Maurizio, can you hear me?
Yeah, I hear you perfectly now.
Okay, Maurizio, I've introduced both you and Gail. Hello, I'm the moderator,
Yeah.
my name is Tamam. And I've introduced both of you, and I'll give you both the next about 15 minutes to give your presentation. Thank you very much.
Okay, perfect. But just tell me give me the green light when I can speak.
You can start now, and just to be clear, collectively we have about 15, less than 20 minutes for the two of you, just so we can keep some time for questions later.
Okay.
Thank you.
So as I was saying during the presentation, my name is Maurizio, and I'm the health coordinator for ICRC for Somalia. Okay, now there's some difference of times in the connection.
Yes. No, but we hear you perfectly well. You can go on.
Okay.
Maurizio is Nairobi, and the internet isn't necessarily as fast as we'd like, but and he's frozen now. Yes, Maurizio, could you hear us and start, please?
Okay, perfect. I was saying that, I'm the health coordinator for Somalia. Now I'm here since July last year. Now, as you can imagine, Somalia, we are talking about access, but as for the country where the different context, the access is not, let's say, 100%. It's ICRC has 4 hospitals. It is supporting 4 hospitals in Somalia, in Mogadishu and south of Somalia, Kismayo and Baidoa. We can say that we gain more and more access, if we can say so. I mean, when I talk about access, it's just flying in the main city and going from the airport to the office hospital. We don't have any freedom of movement outside of the city, for the reason that you can imagine. Since last year, when I arrived, we could stay in Somalia for just for 2 or 3 nights. And now, step by step, due to our networking, our activities in the field, we succeed to stay till 10 days. Currently, we have a surgical team in Mogadishu following in one of the hospitals, following the activities. Of course, I'm not talking about working day and night in the hospital. We're talking about going there in the morning, following activities, doing training, and coming back in the afternoon before 4 o'clock. I mean, that's where we are. We count for the future to increase our presence and to stay longer and longer and longer. Probably, I don't know, maybe in 2, 3, 4 years, who knows? Probably we'll be able to go back as a delegation in Mogadishu. But it's not for now, for the time being. At the same time, I can say we are not following activities in full remote control. Okay, because we succeed between me, Gail, our field officer, we succeed to spend some on weekly basis to maintain our presence in one of the hospitals. I will leave the floor to Gail to go into technical things, and I think it's much better.
Thank you. Thank you, Maurizio.
Good evening. Okay, so thank you, Maurizio. I'm Gail. I've been working with ICRC for about 7 years in various hospitals, mainly, and coming to Somalia and working in the hospitals has certainly been an experience. Having a project that's in remote control management and moving out of that has meant that the whole process is a bit of a process of discovery. And we learn more every time we go into the country about the challenges that we're facing. Or actually the challenges that the population there are facing to get healthcare. So, I mean, security for us as people living in Somalia is not obvious. We don't see fighting like there is in Yemen and Syria. It's very much a protracted conflict in Somalia. So, you know, our risk is being in the wrong place at the wrong time. But the hospitals are still getting plenty of weapon wounded, and that's sort of the population that ICRC traditionally focus on. However, the shortage of good healthcare in the country means that we're having to look at wider services, and that's where the primary healthcare program that ICRC support, the Somali Red Crescent to run, comes into play. But as a nurse, the challenges that I face are that you see the needs are huge. I think when we're in remote control, you sort of know the needs are there, but it's not quite so obvious. But yeah, when you're traveling to the hospitals themselves, and you can see that there's people there who are trying to hold these hospitals together, but you know, there's no budget, they're very much in survival mode. There's not a lot of strategic planning. So when we are there, we're just trying to bring these hospitals to a level where the services in some ways are, they're not totally basic, but they're also not advanced. It's very, very normal services that we're trying to provide. Yeah. So when we're trying to help with the management and the clinical care in these hospitals, some of the challenges that we're facing is the other influences and the other motivations that exist for the hospital staff and the management teams, the local authorities, clan dynamics are a huge part of our daily experiences when we're actually in Somalia. You asked me if I had experience with telemedicine, and as one of the things that we have looked to develop in Somalia is telemedicine, but that requires a secure and safe internet connection, and even that is actually a challenge. We've helped to introduce internet into all the hospitals, and it allows us to talk with the hospital management teams or even clinicians, but to have even digital transfer of photographs or x-rays or anything like that can be quite challenging. So as a reliable way every day of trying to work with the hospitals, it's not always available. So at the moment, for us, the use of the internet is more on a sort of advisory and consultation with management, and sometimes the doctors between themselves talking about cases. Some of the other challenges that we have, because we're not in the field, is we all like data, because it helps us to measure the activities and the quality of the activities. One of the issues is it's difficult to know that your data is always reliable. We have field officers who are working in the hospitals regularly, but even they're not there every day. So, having standardized definitions and common understanding on even basics like that can be quite challenging. So when it comes to analysing information, trying to work out trends, it's challenging. Yeah, it's difficult. So travelling into Somalia for us as mobile staff, you don't feel immediate threats or anything like that, but we have a very wide network with ICRC. We have a whole security team anywhere where we're going who are preparing the ground when we're travelling. When we're in the hospital, we have a security team with us all the time. And this is something that has always been addressed, the risks of being in these places. And so far, over the last 2 years, as Maurizio was saying, it's improving.
But then also, to find yourself, to find yourself in the wrong place at the wrong moment. This one is one of the things that all of us has in mind every time we travel to Somalia. Of course, there is an assumption of risk. It is for all of the people going to the countries the same.
This is very interesting, Maurizio, because there is a significant difference between having an accident, as you say, finding yourself in the wrong place at the wrong time, which is largely uncontrollable. Do you have a feeling that whether in Somalia or in your previous experiences in Afghanistan or in Iraq, in the case of Gail, that you've been targeted or have seen an increased risk that is intentional towards aid workers?
No, actually, as Gail was saying, we don't have that feeling of being target or threatened. No, we don't have that feeling. The only point for us is, as I was saying before, is to if we can, is to avoid explosion, to avoid attack to be in the middle of an attack. You know? But so far, probably thanks to our emergency response, to our activities, you know, this gaining trust by the population, by all the clans, all the people involved in the conflict. We don't have any. Let's say we don't have the feeling of being under, let's say, under the eyes of some group.
And you've talked about your perception and your sense of risk when trying to visit or be around, and that of your field officers. How do you feel that the patients, the population, feels about coming and accessing healthcare facilities?
It's not. I mean, for the population, it's very difficult to access all the health facilities. But it's not just for. I mean, in Somalia right now, it's not just for the conflict, for the different kind of conflict. Because I mean, as probably most of you know, Somalia is having this clan clash. There's Al-Shabaab, there's also the government, there's some different stuff. But it's not just that, because now it's also the difficulties for the population is the rain season. You know, now in a part of Somalia is completely isolated because of the floods. So most of the people, they are just, you know, gathered in one camp, waiting for some help or from some assistance by the few organization currently in the field. So I say it's a daily challenge for everyone approaching a health facility. Okay, and not because they are targeted, because they can be stuck in one of the conflict that can happen all over the sudden.
Thank you. I will allow for any questions if you have for Maurizio and Gail.
Okay.
Do we have anything online? No. Using the opportunity, I think what Maurizio is saying is quite interesting, because most of what we'd consider natural catastrophes, like, for example, the Horn of Africa, Somalia particularly, has seen a massive nutrition crisis in 2011 that forced many people out of Somalia into Kenya and Ethiopia. And it's essential to understand that the conflict makes coping mechanisms so fragile sometimes that what a weather phenomena could push a whole community over the edge and cause a widespread famine. And both the ICRC and MSF has worked in the camps that resulted in Ethiopia and in Kenya after the famine in 2011. Good. Thank you very much, Maurizio and Gail, for your presence. I'll move now to Merce Rocaspana, who's a medical advisor in MSF Spain in Barcelona. She has worked as a medical coordinator both in Syria and in sub-Saharan African countries, and has recently actually been supporting a hospital in the industrial city in Aleppo and the Turkish-Syrian border. And she will tell us about that. Please, Merce.
Okay, thank you, Daman.
Okay.
Thank you very much.
Okay, so what we are doing in Syria is we are trying to provide healthcare to the population which is in extreme stress and in danger. And we have two main strategies. One is to try to run our own facilities with our own staff in Syria. And the other strategy is to support existing facilities run by other organizations or associations of medical staff in Syria. MSF Spain is mainly working in the north of Syria or in the south. So I'm going to talk about the experience I have about the interventions that we were doing in the north of Syria, in Aleppo city and in the north countryside of Aleppo. The challenges are quite a lot. I'm going to try to tell you more or less most of them in these 15 minutes that I have. So one of the main challenges is how we, as MSF, with quite a lot of experience in other war or conflict contexts, have been able to adapt ourselves as an organization and also as professionals to a context where the characteristics of the staff and the characteristics of the epidemiological profile is quite particular comparing with most of the experience that these professionals in MSF had before. Most of us had experience in Africa. Most of our tools and protocols are more adapted to African countries or what we call low-income countries. So in Syria, which was considered a middle-income country, quite a high level of academic education for doctors. So the medical staff in Syria, mainly the doctors, have very high qualifications. And the protocols they had, the way they worked before the war, the access to diagnostic capacities, the treatments, the knowledge they had was quite complicated for them to adapt to a precarious situation. So they have to suddenly adapt themselves to work with very few drugs, with a limited list of equipment and material, and we have to adapt our protocols to this. No? So at the beginning for MSF, when we were there, they were telling us that we were using tools not adapted to Syria. No? At the beginning they said, you are thinking that we are like in the African wars and we are different, so these kind of tools, very simplified, are not useful for us. Now, unfortunately, as the situation is worsening, the situation is going more precarious, I think the experience of MSF is more and more needed and valuable. But during all this time, all this relation with the Syrian staff has been a dynamic adaptation from both sides. No? So we had to adapt to a context with different profile in academic and also epidemiological profile, and they have to adapt to the precarious situation and the simplified tools. This, together with the general lack of staff, whether because they just died, they were killed, they left the country, or just because these profiles are inexistent in Syria. No? So there were many health staff killed during these years of war. There were, as we said, no, students or doctors without the proper qualification as a specialist, working as a specialist. There is no program of training for them, and then these high standards of the medicine in Syria are worsening during the time. No? As the war is longer, the level of knowledge that they have, and also the perception they have about the standard of quality is changing. So some examples is there is no psychologist because it doesn't exist. They don't have clinical psychologists, so you can imagine there are a lot of mental health problems. so we cannot provide proper psychological support to the patients. There are very few gynecologists. Let's say that there's no gynecologist today in this area. And the midwives that were just also before the war, the academic level of background of the midwives are not enough to replace today the gynecologist. So there is a big gap in this area, in the area of the reproductive health. So when we talk about the healthcare and the victims of war, we have to talk not only about the direct wounded by the attacks, but also these people, no? Mothers, pregnant, chronic patients that cannot access healthcare. Hospitals sometimes are half empty. It's not because they don't have patients, they don't have things to do. It's because they discharge the patients sooner than recommended, because they want to have place in case they receive new wounded or new patients. And also because patients don't want to stay in the hospital because they feel unsafe in the hospital, because we all know today that hospitals and medical mission in general has been targeted in this context. So this has a direct impact on the evolution of the patients. So there is no possibility to do a proper post-operative follow-up of the patients. There is no possibility to do a proper follow-up of newborns or a mother who just delivered some hours before, because they are leaving the hospital in a few hours. And we are seeing also the long-term post-surgical infections. As Gail said, there is one of the difficulties is to gather this data. So they are so busy working, doing the job, that it's quite difficult to request them to sit on the computer to write you a report on how many cases they are seeing every day and all the different characteristics. So we tried also to provide them with simplified tools to collect the data to help them to analyze which is the situation and which could be the best solution or measures to help the population. I mean, there were quite a lot of cases, no, of staff that they were requesting us things that we don't use in MSF. They were calling us from hospitals requesting equipment, for example, for the blood bank or for the operational theater, machines, no, equipment to do the surgeries, these kind of things. And then we didn't have proper data, how many cases you have per month, how many, which is the outcome of this, why you use this kind of equipment or this other. So we were trying to get this data to justify the things, and usually in MSF, no, we are quite, let's say, paranoid with the issue of the data and the justification for everything, because we are quite responsible with the money, with the resources that we receive from the donors. But in this case, we recognize that we have to be somehow flexible with the information we get from that, and we have to do an exercise of confidence. So during all these years, we were able to build this confidence relation, and so we were validating products that we never bought in MSF before. So we had the medical department, at least in Barcelona, doing big efforts, the medical and the logistics, to validate manufacturers and providers for medical equipment for Syria, because there was specific cases, things that we never use in another country. All the challenges that we have is the issue of the protocols. They have their own protocols. We have our own protocols. So we are supporting facilities that they are requesting a kind of drugs to use in a way that we are not totally agree, but we accept that this the way to help them. No? So we make this adaptation. So we are trying to to provide them training, mostly now, because we know that, as I said before, no, the lack of technical support that they are receiving. So we consider that they need this dialogue. No? When they request some drugs or some material that is not according to our protocols, we are trying to say if we can train them or help them giving some technical support. This was the case of when there were, for example, this adaptation of antibiotics for the post-surgical patients, or we provide them with protocols for victims of chemical weapons attack. Also, we did a specific training for cholera, because there was an outbreak in Iraq last year, and in Syria they were fearing that this outbreak of cholera could pass the border and enter in Syria. So they were quite concerned about this. We were not very much concerned about, but anyway, there was a request from them, so we tried to help them also to provide with this technical support and training. They are now, let's say, producing nurses in a very short period. They have a new nursing school that is, producing nurses every 6 months, and we try to help them with material, with mannequins, and all this kind of stuff to help them. Other things that has to be adapted, for example, is the immunization calendar for children. We know that the coverage of immunization is very low today for all children under 5 that have been born since the war started. And we were trying to recommend and to implement simplified calendars of immunization to be sure that a child is fully vaccinated as soon as possible before the child is 1 year old. And this is completely different from the national protocol in Syria, which it was in another way. No? So we had also to justify and to negotiate with them. Yeah, I mean, other things is, for example, challenges is the malnutrition. There's not a lot of malnutrition. I mean, we cannot compare this with what is happening today in Nigeria, but it's true that they have some cases of malnutrition, and some of them related with chronic condition of the children. And I remember when in 2013, when I was there the first time, a doctor called me from Aleppo, and then he told me, I have in front of me a child like the ones in the TV. I said, what do you mean? Yes, it's like a Somali child in the TV, and I don't know what to do with him. I said, oh, okay, so we have experience on this, no? So I think we can help. And then we help them how to use the diagnostic tools that we have, and the therapy that we use in MSF and in other agencies that they never had these cases before. No? So today the situation is different, because when we were preparing Aleppo for this siege that is suffering now, at the beginning of this year, we had meetings with all different actors and NGOs working in Syria, most of them small Syrian NGOs or associations. One of the things in the list was malnutrition products, no? to treat these kids. So, I mean, this is the way of, I think we impact, we influence, we help them to take care of these patients. No? And we were able to provide them with more therapeutic food for this BCH situation. So other things that were quite challenging is, for example, the immediate assistance to wounded in case there is an attack. There is this strategy of double tap. That means that there is an explosion somewhere, you send a medical team, and then there is a second explosion because the target is that medical team that went to give this assistance. So Considering this was quite complicated for us to provide immediate assistance and evacuation of wounded. And then in 2014, we adapt a new strategy we call scoop and run, trying to have more patients evacuated in a safest way. But unfortunately, this, after some months, we have to cancel because the insecurity, even with this new strategy, was too high. So we are trying to adapt a lot. The first that they are trying to adapt to the situation is the people in Syria. So we, from MSF, I mean from the offices or from Turkey, from our bases, I think we are doing a big effort and we are learning a lot. But who is doing the job is the Syrian staff. So they are the ones doing the most part of this effort of adaptation and changing protocols, and we are just there trying to help them to make the best decisions and providing them with everything that is not possible to purchase or to be provided inside Syria. No? But for example, ambulances, we were thinking to provide them with new ambulances this year, and they say, okay, very good idea, yes, please, we need ambulances, new ambulances, but please don't buy the ambulances in Turkey or in Europe or in Japan. Try to buy the vehicles inside Syria, because as you know, no, if you have a new car, you know that everything is electronic. So if you have a problem in the car, to fix it, the first thing you need is a computer. So they don't have these capacities there now. So you provide them with a very super fancy, sophisticated European or Japanese ambulance, and in 6 months this ambulance will be absolutely useless. So, you know, this kind of things that you try to do your best, but you have to listen them. Other things that MSF changed, for example, is, well, the first was this, no? Just providing drugs and technical support from the distance. As Taman said, usually we are doing direct care, and we are there for proximity, these kind of things, but in this case, we decided that we had to do in another way. I think it has been possible, and we are doing a lot. So now is, I think, the most important part of our job in Syria is doing this, is giving this support. And then, for example, other things that we went even further in these new approaches is that we are not just providing with medicines. In some cases, we are providing also with the fuel for the generator. So it's not medicines, it's something else they need, no? Because if they don't have fuel for the generator, they cannot run the electricity in the hospital, they cannot do the surgeries. So we were providing fuel to the hospitals. That is something new for us. We said that we were doing in Syria things out of the box, and finally we decided that we don't have any box in Syria. And we are always, every decision that we take in order to adapt our standard protocols or ways to intervene, just for you, I mean, to don't be too worried, is that are very much debate. I mean, we have internal discussions, we consider pros and cons, and this, trying to be always ethical, trying to don't deviate a lot our intervention from our core principles, but this sometimes is a long process, so we have to balance this, to have a long process of discussions to check if this is according or against our principles, or just, I mean, react and give attention to the ones in danger today. I mean, they cannot wait 6 months that we change a protocol or something. No? So this is quite difficult. So we are trying our best, but it's complicated to do in many occasions. Yeah, can say many things, but I think it's enough. So.
Thank you very much, Merce. Thank you. And these are indeed some of the dilemmas in Syria and other places. What I will move to next is one of the solutions actually that we have been using, and this is called telemedicine. And this isn't only for Syria or for places where we don't have access. This is also for places where we have access. But as you may know, many of the physicians that go with MSF go with general experience and then are faced with some of the very complicated cases that they haven't seen before. To overcome that, we have created a tool called telemedicine. And telemedicine isn't unique, it's known, but what we've done is make it applicable to some of the remotest places in the world and put enough experts to advise our staff, both when we have access and when we don't. To speak about this, I'm going to ask my colleague Daniel Martinez to join us. And Daniel is a pediatrician from Mexico. He is also studied a master's in public health and has worked both in the field and in headquarters in Sydney, of MSF in Sydney, in Barcelona, and now in Geneva. He helps our team in Geneva, the Mother and Child Health team, and he has been a referent for telemedicine in Barcelona. So I'll thank you for joining us, Daniel, and I will kindly ask you to tell us about telemedicine.
Hi, good evening. Can you hear me well?
We hear you very well, thank you.
Okay, so it has been very interesting to have the setup and all the context that you have highlighted, and all that keeps to my mind is what the last part of your mention. I'm not going to here to bore you on telemedicine because it's not a new thing. What we have been seeing in the last years when we've tried to come with new solutions is what does really work with all the given situation that our colleagues of the Red Cross and you have explained and Merced has explained. We're giving into a very not only unsafe, unstable and unpredictable context. So every time, sometimes we come with the idea of let's try to connect at least our first line responders to experts. We think on very high-tech solutions. We think on, yes, let's just have the surgeons in Syria with cameras and then colleagues on the other side helping them. Or we think of having somebody being able to help them in the emergency room. Those are the solutions that today are challenging. There are several examples that actually it can work. In Syria, there has been interesting pilot project, not only by MSF, but by other organizations where they have been able to even do medical rounds on a weekly basis or 2 or 3 times per week for specific high dependency areas within Syria. But these solutions have required 2 things that are very challenging. Some that you have mentioned, the dependency on the connectivity. And then you need electricity and a broadband internet connection. And the second thing, you need full availability of people on the other side. And that's hard to reach. So what we're trying to put is to think on the 2 other things. We have already, and we have been developing for already more than 6 years, a large networks of experts from different backgrounds. But they have a key added value. And this is something that is not easy to reproduce in other settings. And for example, the Red Cross uses the same portal of telemedicine. It's people that have field experience. They understand the concept of resource limitation. We don't want just to have 10,000 experts that are maybe the best in the world, but they cannot adapt their answers, and they would ask a skin biopsy for every case of leprosy that arrives into the field. We require people that understand that in specific context, they need to give their best advice given the conditions of the place. And we've seen a real added value for example, radiology, dermatology, or specific conditions where we know that the clinical expert eye really can replace and can complement what the first line medical doctor or nurse or clinical officer is seeing. That clinical expert eye can replace many laboratory and very expensive tests. So we could be investing in giving back a full laboratory support or a CT scan or very expensive tools, but we can also think of bringing this expert eye that is hard to find, and having the expert eye that in combination of having somebody that understands resource limitation concept is key. And that network, it has been very complicated to consolidate, and as you understand, it's hard to get experts in everything. So the second thing is that it needs to be a low-tech solution, something that allows all these experts to connect through a low-tech solution that can be accessible either to a mobile phone or a computer or any portal that requires minimum satellite connection, something that would barely go through some emails, and that allows that communication. And then, once the system has received the case, the system can discuss it with several experts and then channel back an appropriate response. So that's the two things that we think are interesting. The consolidation of a very particular network of experts, and then basing our system more on low-tech, but that low-tech to be also having the minimum requirements. And also, for many years, many of us in the humanitarian setting, we have been doing telemedicine. We have been having a case, and we call through phone or through satellite phone. We send a fax before, now mail, and then we were exchanging personal data of our patients. We want this low-tech solution that we're proposing to be reliable, secure, and ensuring basic confidentiality of our patients. We don't want to have any lower standards for our patients in Syria or our patients in Somalia or our patients in the north of Nigeria than any other patient that we will be treating in what we call a developed setting. So if you have a low-tech solution that ensures you the basic guarantees and ethics of medicine, and you have that expert network that is readily available, right now we've been able to provide around less than 5 hours response to more than 4,200 cases. And right now what we are trying is to see the other challenges that we have is, for example, limitations that can arise as on the language. So, for example, our current MSF system exists in only Spanish, French, and English, and we struggle to have a direct network that can answer to the clinician. For example, if they submit a case in Arabic. Today, the system, if they submit a case to Arabic, we need people in Amman or in Turkey that translates the case into English and then submit the case into the platform. So that today is a limitation for our system growth in some places of the Middle East. But I see it as an opportunity because it will also help us to consolidate our links with all the communities of experts that know better the Middle East, so that speaks Arabic, and that has been already done by other organizations that have been able to communicate better with the Syrian diaspora that speaks Arabic and that have the expertise, for example, for dialysis cases, and they have been able to do direct telemedicine support into Syria. That's more or less how I see this, like trying to adapt, and then once you have set up this low-tech, simple solution, you could think then on adding ad hoc, more interesting solutions. So, for example, then trying to connect. When you have established, for example, for hospital settings, yes, let's try to set up weekly medical conferencing for discussing cases to keep on challenging the young doctors that are today now completely deprived of this academic stimulation, and that could be also relevant for them. Also, trying to have creating or empowering internal network communication among experts and among doctors within Syria. Today we know that these networks already occur, but using non-secure systems such as WhatsApp or Skype. So what we would like is to help also consolidate the network, the exchange of information between the medical personnel within Syria, but through secure platforms that would ensure that when they're exchanging sensitive information, for example, of war wounded in one place in Syria, that they could funnel that information to other colleagues without being afraid that that information could be intercepted. So that is also part of the type of tools that we could be providing to our colleagues in Syria or other places in conflict.
Thank you very much, Danielle. I'll tell you a couple. Are there many medical people here? Could you raise your hands if there are a few medical people? There are a few. One of the things that are, I think, a dilemma in being a physician is having to reflect confidence that you know what you're talking about, and knowing that there's very little that you actually know in the bigger scheme of facing a human, a patient who needs to be diagnosed and treated as best as you can. As years pass, the amount you know, the experience that Danielle was talking about increases significantly. But there is a specific sense of horror that every time you see a patient, am I going to be able to provide the diagnosis and the treatment that person needs? And if you are here in Madrid in a hospital, the guarantee you have is your colleagues, is being able to pick the phone and call someone to help you look at it. And when you are in the field, we want to provide that backup, that sense of security that we are, as medical people, doing everything we can to every patient we have. I had that experience in Congo, in a small hospital we have. Well, it's not small, it receives 10,000 patients a month, but it's still in a small town called Bukavu in Congo. And we had a patient that we didn't know how to treat. And we ended up taking the dust off a very, very old echography machine, trying our best to take the boy had a tumor in his abdomen, and took photos with an iPhone and sent them on telemedicine. We got a diagnosis and a prognosis within hours. This is something you can't get without some backup. And the point, in my view at least, is not only the platform, but it's the people who sit behind it and give you confidence to diagnose and treat. Thank you very much, Daniel.
Yes, I'm happy to be answering on the webinar some questions if they have.
Any questions to Merce or Daniel? Okay. Yes, please. As you like.
This question is for Merce.
Yeah. Mike.
Hola, buenas noches. Good evening. So, I'll do it in English. So castellano, vale. Mercé, ha sido muy interesante tu exposición de cómo os habéis adaptado a las necesidades a lo largo de estos años. A mí me han surgido dos dudas como médico y que he vivido otros contextos distintos con MSF y aquí en Madrid. ¿Cómo habéis tratado, cómo habéis dado seguimiento a las enfermedades
chronic conditions, cardiovascular or infectious diseases? How have you followed up diabetic patients, hypertensive patients? How have you treated those patients or patients with other infectious diseases such as HIV? And another question I have is, you spoke about the medical staff and how they had to adapt to the new situation. And my question is, how did you manage the frustration that these people have had to face up to, and the stress that they must have felt when they saw that they had to adapt their protocols to situations where they really had no resources whatsoever?
Bueno, pues te contesto primero a la
Well, I will first answer the second question. For our staff from MSF, we have, they receive psychological support as they receive for other MSF missions. There's a unit in MSF that provides support both to national and international staff. But in this case, in addition to that, what we have for
que está dentro de Siria, el
people
personal nacional,
in
es un
Syria, for
psicólogo
national people,
que
is a
puede,
psychologist
tiene permiso, o tenía,
that
por lo menos, supongo que sí lo
has a
tiene,
permit, I
para
guess he still
entrar,
has it,
cruzar la
to
frontera
cross the border,
y entonces
and
va de forma
so
semanal, en ocasiones va
he
más de
makes
una vez
weekly
por semana,
visits.
entra y tiene
He enters the
reuniones
country
con
and has
ellos,
meetings with them.
son voluntarias, ellos
These
se
are
reúnen con el psicólogo que
volunteers,
quiera y
and
además está la posibilidad también
there's
de
also the
conectar por Skype a
possibility
distancia con psicólogos que les pueden
to
apoyar desde Europa.
talk to European
Es
psychologists
interesante que al
over
principio de esta
Skype.
intervención, cuando estábamos en 2013,
When we started in 2013 and we had some safety problem and we offered support to our staff, they just would rejected that still a great taboo in Syria with mental illnesses. This is a taboo topic. So when you have a mental problem, you're just branded as a madman, as a lunatic. So they really were embarrassed to ask for support. And then I went back in 2015, and that same staff were, well, they were very thankful, and they were asking for further support. So at least with our staff, we managed to overcome that taboo. Of course, we can do things better, but with the tools we have and the low resource availability, because there's no psychologists, they're very thin on the ground, so that's what we have. Now, in terms of chronic patients, you were asking, within the protocols of MSF, the treatment protocols of MSF, and what we have in our different catalogues, all of that was provided in our hospitals, and we also had, so there was a long list of drugs, and some of them were not even on our catalogue. We also tried to make them available to the population, but it is true that some drugs that, are not available. Second and third lines, certain types of insulin for some patients are not available. So a very complex topic for chronic diseases is medical emergencies, because surgical emergencies are given priority, of course, but medical emergencies are not that they're not considered to be that urgent. So some patients with medical emergencies could be in for a negative denouement. And it's interesting to see how they establish priorities in the ER as to where to start. And knowing that, and of course we're going to have more and more medical emergencies, because support to chronic patients is lower and lower, because the availability of drugs is non-existent in Syria, because all the drugs being used come from abroad. They're donated by MSF or other organizations, and so not all medical structures have drugs, and not everybody has a medical center next to their homes with people, with doctors that can provide a good diagnosis. So there's a dearth of personnel and a dearth of drugs.
Thank you. We'll show you a little bit of a small video about the use of telemedicine in South Sudan. If we could roll that, please.
Hi, my name's Kay Hodgetts. I'm a medical doctor from New Zealand. I started working with MSF at the beginning of last year and recently completed my second mission. Last year I worked in the Somali region of Ethiopia with a population that had been affected by a prolonged period of conflict. We worked in both primary and secondary healthcare facilities and operated a number of outreach clinics also. During that time, the bulk of the work was in paediatrics and malnutrition, but we really saw a little bit of everything. More recently this year, I worked in Leer in South Sudan, again in primary and secondary facilities on either side of the conflict. Again, pediatrics, malnutrition, a bit of a mixture of everything, and a lot of violence-related injuries, a lot of gunshot wounds. When I arrived in my first mission in Ethiopia, I was the only medical person in the project at the time. During a ward round on the pediatric ward in my first week, we had a case of suspected spinal TB in a child, and one of the national doctors working in the hospital suggested that we put the case on telemedicine, which I hadn't heard of before, but found the login details on the computer and uploaded the case, and was so impressed by both the quality and the speed of the response that I received that I didn't look back from there, and continued to use telemedicine for many of the complicated cases that I saw. And then Daniel, one of the coordinators of telemedicine, suggested that instead of just reserving it for complicated cases, that we utilise it as on more of a routine basis, which was great because the benefits of using telemedicine go far more over and above what the benefits for an individual patient are. So that was fantastic. Since I first found out about telemedicine, I've used it for roughly 20 patients, both in Ethiopia and South Sudan. And this would range from simply uploading a picture of a rash or an ulcer or an x-ray to uploading videos of demonstrating neurological signs in patients. Sometimes the correspondence would go back and forth over a period of weeks or months for a particularly complicated case. Yeah, there was one case that I dealt with in Ethiopia where telemedicine was particularly helpful. I was dealing with a 4-year-old Somali boy who was malnourished and presented with fevers and found to be pancytopenic or had very low blood counts. And he wasn't responding to our initial lines of treatment, blood transfusions, antibiotics. And via telemedicine, we were able to access the assistance of a number of specialists, including a pediatric hematologist, who helped to guide some of our decisions to refer the child for some more specialist tests, including a bone marrow biopsy. And subsequently, we utilised the specialist assistants to interpret the results from that and help guide some treatment decisions. And ultimately, the child was able to be discharged well after 2 months of being an inpatient in hospital. So it was a successful outcome and gratifying for everybody involved. When you're dealing with complex patients in these types of environments, without the usual investigations, you often rely on your clinical findings and being able to relay these to a specialist who has more knowledge and experience, expertise in the conditions, the type of conditions that you're dealing with is very, very helpful. It just gives you an extra level of support that you otherwise wouldn't have. Probably the biggest advantage I found of telemedicine was that it ameliorates some of the isolation you might feel as a doctor practicing in the field, dealing with cases that are within the realm of specialties that you may not have a lot of experience in otherwise. You have instant access to an enormous amount of expertise from around the globe in a range of specialties, and it's a very empowering level of support that you can access this advice and assistance and apply it to your patient and use it as a learning tool for the rest of the medical team that you're working with also. If I were to be at home working in a tertiary hospital, I would always seek out specialist advice for these types of cases. So why not do so when you're working in the field if you have the technology available? Sometimes the speed with which I could access a specialist via telemedicine from South Sudan was faster than when I'd be able to do so working in Australia. So that was fantastic. In Lear, the situation was extremely unstable and we had very, very limited access to investigations and resources. We weren't able to look things up on the internet if we'd wanted to, so being able to access telemedicine and advice from specialists in that type of setting was invaluable, really. Another advantage of the service is that when you're dealing with specialties in which you may not have a lot of experience previously, you can access advice from experts in their field, such as ophthalmology. One time I had a patient with difficult eye problems, and the ophthalmologist I was able to access via telemedicine was able to provide me with information on how to make a homemade ophthalmoscope to look at the back of the patient's eyes, and also how to make antibiotic eye drops from the medications that we had available at the time. When you feel like you've exhausted all of your lines of treatment and investigations and the guidelines aren't telling you where to go next, specialists via telemedicine can help you to think outside of the box. Of course, it all comes down to how you utilise the advice and apply it to the patient in front of you. But another benefit is that you can relay the learning points from the case to the national staff, the medical team on the ground. So having uploaded a case, it can become an educational tool for everybody involved, not just benefiting the patient. I hope that telemedicine will continue to expand its profile and capacity, and I look forward to using it again in future missions.
I would like to, I have saved the best for last. Dr. Jean-François Saint-Sauveur is the medical director of MSF Spain. He comes from Haiti originally and has worked both in the fields and in the headquarters. We would like to hear from you about organizational responsibility.
Thank you. Good evening and wake up. Now, after the video, we had a kind of a dark room, so I was saying maybe some people will sleep. So at this stage, I think that I was requested to give a bit of perspective from or talk about the institutional perspective from MSF. This is a huge task, okay, in which I don't think that this is something that, first of all, I myself, as the medical director for one of the operational centers, can fully answer, because MSF is a very big organization. It is an organization now which has the same age than myself, so I will not tell you. You Google, and you will find out. And that has worked in so many situations. Have done great work around the world, and particularly for the most vulnerable people that we see. The situation about which we are discussing tonight is a very complex situation. We are talking, just to put a bit of perspective, maybe for those that have not seen, a bit of propaganda, but it's not propaganda, for this article that you can find, I think, outside, Changes in Medical Practice in Syria. And with the examples that we have been trying to give, is to let you know that the context in which we are called now to operate is becoming ever more complex. And as you have put it in the introductions, it's abnormal. So we are being confronted with situations that for sure we were not ready, and we are not ready even to confront them. We are talking of a situation now that, okay, from the Somalia, South Sudan, Ethiopia, all these contexts are protracted conflict, and some of them are acute conflicts, like in South Sudan. You have heard of the Central African Republics. In the other debates that you have seen that MSF has brought you, and you can see them also for sure on the news, we talk about the context. We talk from the international humanitarian law that is not being respected. There were other debates that talk about more the access issues. That was the last debate that you have. And tonight we come to talk about the relationship between, I would say, the healthcare provider and the patient and the target population and the beneficiary. This is what we try to address with those examples tonight. So from my perspective, I'll try to just address very briefly on three kind of maybe questions, because we have more questions now than answers. Because as you will see, or you have read and you have seen also even in the videos that we have on our website, by Syrian doctors that have also told us about their current experience. I will talk about what is the institutional responsibility with these changes that we have been kind of giving you some examples of them. How to find the balance between risk and benefit, because as an organization, we are saying to you that we are sending people to places like Syria right now, where healthcare facilities, ambulances, patients that are already wounded, they are being targeted. We used to talk of situations of residual risk. You cannot never say that there is no risk. That is the situation that our colleagues talk about in Somalia and in Ethiopia. But we have had cases from the years now coming in South Sudan. Our facility were attacked with patients inside, and some of them killed, and some of the staff killed. We talk of the situation that is well known, the one in Kunduz in Afghanistan, where we had hospital bombs several times. Patients died, healthcare workers died, caretakers died. And the situation in Yemen has been examples again that we are having more of our healthcare facilities being bombed. And we have had to take out our teams for some time in Yemen. And now the situation is Syria. I think it's I don't have the English word for it, epitome, I don't know if it's English, of what has been systematic use of bombing or targeting health facilities, ambulances, and patients, and killing them. So we are talking of a situation that is very, very difficult, that is abnormal, and that you may be asking to yourself right now, so how do you deal with that as an institution? Okay, we are talking of now, the first thing that in the introduction that Taman talked about is one thing that is very dear and close to the organization. Part of the way we work is the proximity. Healthcare is not done by robots. Healthcare is a patient that you have, and you have healthcare workers that is care. They try to help. They try to give sometimes of relief to the pain that the people are having. And sometimes we do life-saving interventions, but most of the time what we are there for is to care for the people. So we are in a situation now that those people, the healthcare worker, they are being targeted in some places, and the patients themselves. So if I would invite you really to go to read this, this would be part of the first question that I have, a part of the answer. What is the institutional responsibility with these changes? And even to accept, to go and to still working and support health facilities to be run in those contexts. I think our responsibilities as MSF, an organization that really tries to be transparent and honest in what we do, is to let you know also all the challenges we have, all the things we do, and oftentimes what we cannot do and what we are not really doing. Because right now in Syria, what we are doing is very, very minimum compared to all the needs that are there. Okay? The resources that are being put there, the return that we would have if we would put it in economic terms on this investment, it can be counted in lives. You cannot put a value on it, but if you would put it in numbers, really, it is not a lot compared to all the calamities that is passing in this country. So first and foremost, as an institution, we come to you not tonight to say all the good things we've done. We won the Nobel Peace Prize in 1999 that we should return because so many other people that have won it, we don't deserve to be in that league anyway. But it is not about that. It is about to tell you our frustrations, really. It is more about that right now. We have more questions than answers. We have more frustrations than things that we could feel proud about. When we talk about the changes, we are talking of things that not all the changes that we have done only that have had some benefits. We are talking now that we are confronted with certain situations, we can find there also, that we're confronted with an outbreak of missiles, and we have not been able, not because we are not capable of organizing a mass campaign, a mass vaccination campaign, because if you would gather people together, they could be a target, they could be killed. It is not that we do not know how to answer to an outbreak. And it is happening right now also in Syria. Polio outbreaks they have had. So the changes that we are doing, not all of them, and most of them, I can say, are not ideal. We are not happy with them. We don't feel comfortable with them. In that situation, for example, we are now trying to see if health facilities are target, patients want to stay less and less in the hospitals. Even at times, you can see that maybe our clinicians, they are forced or they feel that they should discharge as soon as possible because you would leave the bed for someone else that needs it. But at the same time, you are putting more risk on the patient, more risk to go home and to take care of themselves. They come to you first so that you could support as much as possible. So first of it, I think the responsibility in this sense for the organization is for transparency, a responsibility to be very much accountable, a responsibility to be vigilant with those changes that are done that we know that are not ideal, and to remain accountable about them. And as soon as possible, as we see that there is a time that we should say stop, we stop. We are not in those contexts for experiment. We do respect the dignity of the patients, of the people that we see. We do respect that for us it is not about the numbers, that we want to invite people to come and to say that we are seeing millions and hundreds of people. But we do know that we have our limits. So the part of it is, first and foremost, for us as an institution to know our limits, to question ourselves day and night, and to keep those red lines very clear for us. The part for the balance between risk and benefit, for us, again, it is an issue of always asking ourselves, who is getting the benefit of what we are doing? We do know that our colleagues that are there, more and more, if we are not able, let me just put another example. It is not that MSF, we are not very much present in Syria with expatriates or with all the doctors. You see situations that they say they only have 5, 6 doctors left, etc. So we are doctors without border. Where are your doctors? Why you are not there? The fact is that we don't feel comfortable not to be there. We don't feel comfortable not accompanying our colleagues, not putting more doctors so that one doesn't need to be 2, 3 days without sleeping and go from one hospital to the other and do it all. We don't feel comfortable for those situations. But the fact is that, yes, there are risks that we are not ready also to put the healthcare workers on. but just not because the organization doesn't want, but just because those situations are becoming more and more abnormal. And you have, and you know about all our campaigns, Stop Bombing Hospitals. These are not just words. This is happening day and night. So also as an organization, for sure, we do have to measure the risk, okay, that we put on people that we send on the ground, the risk that the healthcare worker, be them Syrian, because even though they want to volunteer as Syrians to be doing their job, we know that they have risk. We know that it is not easy for them to do a proper triage, because you have in front of you a combatant that is wounded, and maybe you do have somebody that is very much a humble person that don't come from a big clan, don't have a big last name, or it is not last name in most of those cases. They don't come from those groups. So the healthcare worker, it is not the time, the normal practice that you would have as a health professional, or they would have to do their triage, with all the professionalism, the knowledge that they have, their competencies, and to do that, it is not that evident in that place. So there are risks for the healthcare workers on that. So we always have to measure that. And for the patient, the same thing. We should not, okay, or encourage or be passive if we are seeing that the patient, they are taking on themselves also too much risk. We have to be able to explain. We have to be able not to be happy, because if this patient says, I have to go, I don't want to stay, etc., even if you know, okay, that sometimes it is better for them or to stay, so that you have to, and versus that, you will have one bed free, for example, not kind of be passive. You always have to confront with the situation and tell the patient also what is the best alternative, and that what you think should be best in that particular case. At the same time also, we know that healthcare workers are taking more responsibilities than what maybe they are capable to do, but they are confronted with situations that they have not seen before. We have seen a video, we can see it on the MSF website, for example, a doctor saying that I've seen, wounds that I cannot describe. Okay? Situation that people are not sleeping enough, and that they have to operate under those situations. So we as an organization, we have to always measure that. Is it okay that we let people continue to function in that situation? What about, okay, if we are having most collateral or severe medical adverse events that are prone to, because people are human, more errors that are putting patients more at risk than the benefit that they should get. We as an organization, we want to and keep measuring those things. There is not red lines that we want to jump or to pass versus what should be the safety of the patient that we treat. And last, it's about what is lost and what is gained. I would start briefly with what is gained, because it is very little that is gained in that situation in terms for us as an institution. We do gain because we see more and more, even under those extraordinary circumstances, abnormal circumstances, cruel situations, the healthcare workers, the colleagues that are there, they want to help the patient. They want to support, even at the risk of their own lives. Healthcare workers, there is I don't know, well, the English for a little bit of humanity is always there. So it is not all lost. There are always people that want to help, that want to support, that want to bring this piece of humanity to others, so that people in Syria or in other conflicts that are caught in the middle of those cruel wars, they don't feel that they have been abandoned by everyone. So yes, there are things we gain to see all those things that are coming from our volunteers, our colleagues, and the frontline workers, and that's why we have to try all that we can to give them the support that they need. And what is lost, I think I will finish with that, and it is part of more questions that I have. What is lost is, first and foremost for us, is like more and more we are losing the proximity that we should have with the patient, the proximity to know really what are the real needs, the proximity really to put into the balance. Is are all these people that are getting the benefit, the real target population, are they the most vulnerable that we as an organization, as MSF, we really would treat if we would be under other circumstances? Because oftentimes those that can reach the hospital are the same combatants themselves. Are we helping more combatants to survive than really addressing the needs of the most vulnerable that are caught in the middle of those wars? Are we more doing for the bleeding that we can see than for the bleeding inside? We're more focusing only on the trauma that is more evident than all those that really or don't have a voice or nobody care about, or just because they cannot themselves force their way through the system and get it. And to remain as an organization responsible with the resources we have, the staff that is working with us, and the patient that reach us. But as I would conclude by saying, at this stage, from an institutional perspective, I come to you very humble and very honest in that way that we have more questions than answers. We are not comfortable with what is being done, and we want to try our best. And also, we wait for your questions, but if you have ideas, you are more welcome to share them, because this is about that, and this is about MSF. We want to discuss those situations with you also, and let it start.
Thank you. Thank you, Jean-François. Thank you very much. It's always difficult to measure the extent of our responsibility when we are trying to mediate in what is a very difficult situation. Where does our responsibility start, and how can we balance the risk, as you say, and benefit of our presence or absence? Thank you for that. If we have any questions, we'd be happy to as well take them. Yes? 4? Daniel. So we'll wait until we are at the question and answer. Okay.
Yeah?
Yeah.
So I will ask a question to myself now. I will give the floor now to Tamam, as that will share with us also a personal experience as a Syrian doctor and a humanitarian healthcare worker.
Thank you.
Before the wrap up.
Thank you. It's a little. It was a little confusing for me when I started thinking about answering this question. First, because I don't think I have a standing to talk as a Syrian doctor when my colleagues have actually been on the ground. I haven't been able to enter Syria for years now, except sneakily to MSF projects in the north a couple of times. But the more I thought about it, the more I realized that this is the limbo that I have been looking at for the past nearly 6 years. On the one hand, the reason I chose to work on humanitarian medicine is because I felt that I owe my allegiance, my loyalty to not only my town or my country, to whoever needs help, whoever I can be useful to. And I thought of myself for years as someone who doesn't get affected by national boundaries or tribal, and I come from a very tribal part of Syria, or religious or whatever allegiances. I belong to a universal value that carries that. And then once I started getting comfortable with that, the Syrian war came, and among all the things it destroyed that view that I wanted to maintain. And the reason is, part of being a physician and part of being a humanitarian worker is you learn to create a professional detachment, as horrible as that sounds. You need to keep a balance of empathy and detachment. so you can feel for your patients and you can at the same time not be disabled by your sense of empathy. It was hardly sustainable. And I tell you, Merce worked in Niger, for example, or when in places like Somalia, or after the earthquake in Haiti, or after the tsunami. It's nearly impossible to maintain composure when you are faced with the overwhelming amount of both the problem and people's ability to start trying to survive. And I thought that I've seen a lot of it, that there's little that was going to shake me anymore, that I have perfected my professional detachment until the Syrian war came. This is something I could keep at least a sense of professionalism about, I hope so. But at the same time, there's a personal thing. There are people I knew firsthand. There are family members who have worked and struggled and got imprisoned and migrated as part of this war. There are colleagues I've worked with before who have worked in the underground hospitals, who have worked in aid inside without the benefit of an international organization's contract or salary. And that takes you out, and it forced me to think about aid slightly differently, about my job that I've spent my life doing. So talking about that is not necessarily very easy. But in and around, and this is something I really appreciate MSF for, because the first time I joined the MSF in 2012, I went to the emergency desk manager in Holland, and I told him, look, I am from there, and I was the head of the medical department at the time. And I said, I could benefit you in my knowledge and experience in the country, but I am biased by definition. I'll try my best to do the job as MSF wants it to be done. But it'd be silly of us to believe that I can be completely unattached to my country. And he said, well, we'll see. And we started working on it. And we managed to challenge each other in a way that we think at least we maintained a certain balance. But in the meantime, I still don't feel the right to talk. So I'll give you a couple of things that have happened that I've seen firsthand. And this is from Syrian operations. One of them was a child who's about 9 or 10, who we've seen in Turkey across the border from a family that fled. The child presented typical, and as Mercer said, the situation started collapsing to the extent that we started seeing things we see in sub-Saharan Africa, and the symptoms were clear and visible, although they were completely unusual for the population, because what we were seeing was an AIDS case in a child that was about 10 years old. And as you know, AIDS is either from mother to child or sexually transmitted or by blood transfusion, and the child hasn't had a blood transfusion. The child was most likely raped. And when we told his parents that we actually can bring medicine and initiate his treatment, they asked and we explained. And of course they knew. And the next day, they disappeared. They took their kid and disappeared from the town we were in. And of course, it blows your mind. Why would someone sacrifice a chance to get treatment for a child? The problem is sometimes, and this is one of the things that we could never justify logically, sometimes the stigma that comes with a disease or with a situation overtakes the necessity for treatment. Another thing was another child that we got in Turkey. And this is one thing I like about MSF, is that we at the same time sit and talk about the global picture, but we have the ability to still be concerned about a single patient. We had a child who had, in the middle of a polio outbreak that has resulted directly from the war. We received a child from Raqqa, which is now the stronghold of ISIS. And he had paralysis, so we suspected polio. And we were unable to do anything in Syria because we couldn't diagnose. So we took the kid and his mother and his grandmother, and we rode the head of mission and me rode with them to a Turkish city. And we spent a night there. The child had a different disease. Fortunately, it wasn't polio. He had a disease called Guillain-Barré. And we took them back. The reason we took them back is not because the treatment was complete. We had to take them back because the mother had to go back because her husband wouldn't let her disappear alone. Although his mother, her mother-in-law, was with her. And this is where medicine stops being medicine. You know, you can't do the white coat and the clinic and then the complete, I don't care what happens to you once you leave my clinic. This is where medicine becomes an exercise in engagement with the people you do. You have to talk her into treating the kid. You have to talk her into not losing her family. Who the hell knows what you could cause by advising something or the other? In the end of the day, we arranged for the grandmother to stay with the kid in the hospital and for the mother to go back and assert her presence. At the same time, this I mentioned was in the polio outbreak. As Jean-François mentioned, we've had several outbreaks in a country that had nearly zero infectious diseases. And the moment we talk about vaccines in Syria, I start hearing from my childhood the jingles that used to be on TV for people to go and vaccinate. And this is, we had them all the time on the public TV. When I was a kid, we didn't have satellite televisions, we had one channel. And every day they'll put the songs about vaccinating and everybody was vaccinated. And suddenly, in 2012, we started having drops in vaccine. And immediately, 2 years after the war, you start having outbreaks because the kids under 2 start not having vaccines. Of course, this is part of the paradoxical, horrible bit of the politics of global health. Because we've had thousands of kids sick with measles that we've vaccinated in the north of Syria, and not much response from the global health community. Then we had an outbreak of polio. And mind you, measles kills many more people than polio. But polio, because they have an elimination target, because there's politics behind it and money behind it and big organizations, caused a massive stir. Suddenly everybody was negotiating for more access to vaccines after having ignored measles outbreaks for a year and a half before. The last bit I want to talk about is a hospital we've had in Ramtha in northern Jordan. And in the middle of that conflict, where bombing has happened every day, we had a weird equilibrium where the Jordanian border guard will only allow the worst cases to cross the border and get treated. And we set up a surgical hospital. And there's 2 sides to this. First is they had to see blood. So normal small injuries weren't allowed to pass. People had to be devastated to pass. And we couldn't even be at the border crossing to convince the guards that this is a serious injury, which meant that by a silly decision like that, we almost exclusively received amputations or severe central nervous system, head and torso trauma. We received practically the cases that we could do least about. And they didn't allow the cases that we could treat that within a week or 2 will have infections and wouldn't be treatable anymore. At the same time, one of the best things I've had is a surgeon in Ramtha. And you know, today, medicine is hyper-specialized. So a surgeon, if you go to study surgery, you will be asked to decide, what do you want? If you want orthopedic surgery, you'll go and study orthopedic surgery. In the old days, surgeons used to know how to do surgery of all kinds. And Haidar, who was our surgical advisor, was one of those guys. He was one of the few surgeons today with enough war surgery experience to be able to do almost anything in a surgical operating theater on a war victim. And he stayed there for months because there wasn't anyone to replace him. The amazing thing about Haidar is that about 35 years ago, he started working on humanitarian aid when he was a refugee in a refugee camp out of Iraq. And for me, his incredible skill is one thing, but his story completes the cycle. Haidar had volunteered in that refugee camp to help treat patients, and 30 years later, he's still treating patients out of the same region, and probably saved single-handedly so many lives out of that hospital than we could be thankful for. I think today we've talked a lot about Syria, and I think this is almost sinister because Syria gets so much attention on the news. I am thankful for that because I know how many other conflicts and people do not get any attention on the news. There are shameful ignorance of how many people die of violence every day in many places in the world. There's all the way for us to know it, and there's very few people who care to know it. And this is almost exacerbating the trend that is unforgivable. Because there is enough politics around Syria, we hear about it every day. It becomes what is called a CNN conflict. And today you've heard of Nigeria mentioned a couple of times. You probably heard of Central African Republic and South Sudan. There are so many conflicts, maybe not as brutal on the day-to-day basis. But if you think of Yemen, Yemen has 23 million people. 20 million of them are in need of humanitarian aid. And before the war, 30% of the kids had malnutrition. I think we need to talk about each one of them. I want the conflict in my country to stop, but I also do not want other conflicts to stop being mentioned or addressed as they should be. In the meantime, as Jean-Francois said, it's difficult and it's getting more difficult. And what we hope we could do is be transparent and honest about it and be able to deliver the best medicine we can in those situations. We'll open the floor for questions now. Shall we put Danielle on the line as well, because we have questions for Danielle? And Gail is here as well, so. Is Danielle on the line?
Streaming.
Danielle, can you hear me?
No.
Okay, maybe I can answer.
The questions that came, that Danielle mentioned that Skype and WhatsApp are not very safe communication systems. Can you give us examples of safer alternatives?
Yeah, so I think one of the alternatives is the platform that we have. I mean, what Daniel was saying, and then in the video, what that doctor in the video was describing was the use of a MSF platform for telemedicine, which is safe and is only for MSF. So this is the platform that we have now. And we are trying to develop other kind of tools, but we have already a platform that is.
I think what Daniel means is multiple layer. First, we're not insinuating that the existing systems are hackable or so on. It's the usage of them. You have your phone around, the people can see it, and it can be forwarded, dealt with, seen, and that's not safe. We have a particular concern about patient data. Patient data, we have an obligation, both as medics and in the situations we're in, to keep the identifying data of patients secure. And this is extremely worrying because in addition to the autonomy of patients that requires us to keep their privacy, there is a real risk in some situations. You will have heard of stories where in Rwanda, for example, lists of people were used to guide people who have committed the genocide. We aren't going to allow the data we collect of our patients to be harmful to them in any way or possibly be. And this is where the security of the data system becomes critical to us. The other question is, what are the consequences of not using those safer communication systems? This is exactly what I'm saying. In what we cannot understand necessarily as external observers is that things could be risky in ways we don't comprehend. There are places where just the name of the person will imply their religion, their tribal affiliation, their regional, and it becomes very important to protect it. The consequences are putting ourselves and our patients at risk if we cannot protect their data.
Yeah, I mean, we are very careful because we don't use the names of the patients in this, and even the staff. Some of the staff is working with how would I say, alias, no? I mean,
aliases, yeah.
It's not the real name because they don't want their name written in any document that maybe could be used by the parties in the war against them. So it's a matter of the right to the patient. So one of the hospitals in Aleppo had a system of telemedicine. They were using cameras that were connected with a hospital in another country, and they were providing support from the distance for the intensive care unit. Then when I talked to them to understand how was the system, because we say, okay, if you have a good idea, maybe we can learn from your experience and adapt and maybe do something similar in another hospital. So they just have the cameras but without audio. So then this medical team from the distance could see the patients, but the communication was through WhatsApp. So then at the end, the system that we thought was a super nice system, ICU supported from the distance, at the end was not so nice, no? Because it was not very safe, this system. And then I asked, what do you do if the patient refuses to give you permission, the patient or the caretaker, to be recorded by the camera? And they say, we don't ask. So these are the considerations in the telemedicine. So we are trying to do the things as best as possible.
Just in general, I think this is the main point that we talk. The standard that we apply either to telemedicine are the same or more strict even to what is applicable at that. So the respect for the patient autonomy, their confidentiality is the same. So this tailored platform that we are using, it is made for that. There is nothing that is secret 100%, but we use it because it is a platform that is tailored for that. And at the end of the day, also, these are the things that we have to value as an organization. Where are the limits with working with other staff, etc.? Is that for us, these are not limits that MSF is putting. It is the limits of the profession. It is the limit of the ethics of treating with patients. So it's a red line.
Absolutely. Okay. I think we're coming to the close, so I'll give a last chance if there are any questions. Good. Somehow we're on time despite...
Yes.
Yeah. Thank you very much. We really appreciate your presence. Thanks to the people who have followed us online. And I'll encourage you to also go and see the previous two roundtables from this series. Both are in Spanish, I think, no record. And let us know if there's any feedback you could think about. Thank you very much and have a good evening.
Thank you.